Michael.
Yeah.
Now, again, just a quick disclaimer, we're focusing on a 6-year-old child with regard to what happened. And in as much as childhood illnesses should be part of this conversation, given my background, we're probably not going to be able to delve into conditions like conduct disorder, oppositional defiant disorder, or perhaps even ADHD. So they're kind of off the table for the next 30 minutes. But nonetheless, we could talk about a 6-year-old Michael, we could talk about Michael as an adult. What did you see beyond anger with regard to Michael Myers?
He seemed, I think, possessive a little bit. I don't know if that's the right word, but persistent.
I think it's a large unknown. We don't know why he comes back to Haddonfield, right? So it might be an element of feeling possessive, because it looks like he's after Lori. But I don't know if we know that definitively, and I'm not sure how many sequels this group has watched.
I haven't.
But yeah, it's hard to kind of gain further insight as to why he actually comes home that night. Any other observations? If we think that anger is playing a role with regard to what we see in the behavior of Michael Myers, what defense mechanism is likely employed? So acting out
Yeah.
is an observable action on a forbidden impulse. So that might be anger, and then we see what happens. The idea here is that the individual acts on the impulse so as to ensure that they do not become aware of that impulse, because it is be than anger.
I was like, oh.
I'm kidding, that was not my design. All right, so what might be that forbidden impulse? And might the answer here be related to the question of why he even goes home that night? Right, so I think we have a large unknown, but now we just introduced another question. What impulse can be so taboo that Michael acts out in such a way to do what he does? Because it would stand reason from Freudian psychology that the impulse, or being made aware of it, is even worse than the actions themselves, right? So we have to keep that in the back of our mind, hard and fast. Anything else here? What about the mask?
Kind of like a white expression.
I would agree.
Yeah.
It's also those eyes that the psychiatrist mentions, that there's nothing behind there. Right, so is there any kind of equivalent, or does that conjure an idea with regard to anything relevant in psychiatry? The maskless or faceless expression, the lack of emotion or empathy in one's eyes.
Schizophrenia.
So we can talk about a severe and persistent mental illness like schizophrenia. Sure. Anything else?
Like catatonia?
Could be catatonia, yeah. If catatonia, and you were able to see Michael as a psychiatrist, let's say you were Loomis's colleague, what might you have provided to Michael Myers that may have alleviated his symptoms and therefore alleviated Halloween 2, 3, 4, 5, 6?
Oh, wait, another answer.
Yeah, yeah, and IV benzodiazepine. I mean, could you imagine if this guy became awake and alert and talked to you? I mean, we'd have the loss of a franchise. If catatonia. Catatonia, generally speaking, is a condition in which the individual is not responding to aspects or stimuli from their immediate environment. That's the general definition of catatonia. The much more complex definition is a set of signs that is assessed through a structured clinical interview with a validated clinical instrument such as the Bush-Francis catatonia scale, which is an extensive multi-item scale, a score of which may actually be above the threshold for diagnosing catatonia. Usually what happens is that upon administering the Bush-Francis and getting a score, the IV benzodiazepine challenge will be diagnostic if there's a 50% reduction in that score. That's the general idea. The intermediate definition, right, not nearly as complex as the Bush-Francis, but certainly a little bit more in detail than the general idea, is the American Psychiatric Association's diagnosis in the DSM. Right? That multiple symptoms, but not near the quantity of items in the Bush-Francis. Anybody tell me some of those diagnostic signs published in the DSM?
Something like when you try to, for catatonia, right?
Yes.
When you, like, attempt to wake them up or something, it's, like, they're basically like,
Maybe lack of response?
yeah, just lack of response, and they kind of like are not drooping. I can't think.
Not what?
I was thinking like drooping, like their limbs are kind of
Like they're stiff.
Slow movement,
moving slowly.
like slow, moving really slowly.
Well, posturing would be one. Posturing would be one. Grimacing would be another. But I think the other thing you described is that they do demonstrate negativism. That is, they don't respond to the examiner's quote-unquote commands. So simple commands are not responded, you're ignored at bedside. Negativism. So posturing, grimacing, and negativism. Anything else? We can see mannerisms and stereotypes. Okay? So these are movement focused. What demonstrates the movement of a stereotypy from that of a mannerism? A stereotypy is simply a purposeless movement. Headbanging. Whereas the mannerism is an act that is purposeless, but in the context of an overall larger goal-directed activity. Right? And the example I like to use is Robert Barone in Everybody Loves Raymond. Anybody here familiar with the situational comedy? How does Robert eat? Do you know? For Robert to eat, he always touches his fork or spoon to his chin before putting it in his mouth. The overall goal-directed act is unmistakable. He's eating. But there is a purposeless activity incorporated into it, needing to touch his chin before eating his food. Right? So that's a mannerism differentiated from a stereotype. So this is all published in the DSM. I think the individual is required to have 2 or 3 symptoms, at least with regard to diagnosis. Again, certainly significantly less than the Bush-Francis evaluation, but a little more than the general definition. So, any evidence of catatonia? Now he's negativism.
Well, it's just odd that like he moves so slowly. I mean, it's very cliche, I guess, but in terms of this, maybe he just is physically having trouble moving, and he's just moving so slowly.
One of the things we should probably investigate, and this is more of a quick literature search, catatonia is nothing more than the behavioral manifestation of something that is underlying. So always due to a neurologic or medical condition until that attributed to a mental disorder. For instance, depression, schizophrenia. Now we mentioned schizophrenia already, so that definitely isn't differential. But like in any evaluation of schizophrenia, the clinician must investigate and rule out other potential medical causes or that due to a substance. So if we also think that catatonia would be in the differential, and we think he does demonstrate at least 2 of those signs, then I think we need to investigate the potential medical or neurological causes of catatonia and maybe discover what ails Michael Myers. Because we know that in 2021, rest his soul, Dr. Loomis never was able to figure that out. So it's in the differential. Anything else?
Why he chooses certain victims, prefer being the sister.
Yeah, I think that discussion always starts with Lori. And I don't think we've figured that over the decades yet. I don't think the writer producers have disclosed their secret. I'm not even sure they have one. Right? So I was hopeful with Halloween Kills, but I didn't really get much from it to further the conversation, to clarify things. Beyond that, he does seem to fit the horror trope. Again, this stems from 1978. In horror movies, if you're a virgin, you're likely to live and be the quote-unquote final girl, as women are stalked more often than men. So the final girl trope is real, and that's something that I think is borne out in the 78 original. On the other hand, if you are not a virgin, you are at risk for dying in a horror film, especially a slasher film. Okay, so now I don't know if Michael obeys the rules. Ghostface in Scream does, because that particular Wes Craven film is a movie within a movie. So it explicitly reviews the rules of horror, not so much Halloween. So don't know if Michael Myers really understands as much as Ghostface did. Although I was interesting, in Halloween Kills, one of the things that I thought was kind of cool was that there was mention, I'll be right back. They actually used those exact words, which we know you never use in a horror film. Right? And again, Scream in the 1990s reminded us of that. There's an actual line saying, never say, I'll be right back. But in Halloween Kills, that is actually in the script. And I have to think that was intended. Anything else?
Well, I think going off of that, like, there's so many sexual undertones in this movie. Like, I feel like it was like anytime someone was engaging in like a sexual act or something, that was when he struck. And then the whole trope about how the one who was more reserved and like virginal, she was the one that was saved, basically. So that's what we were actually talking about this earlier, and I mentioned that trope, because then it made me think of Scream, because that was like the ironic version of it.
Mm-hmm.
So I thought that was interesting, that like that had so much to do with this movie.
And then also, again, I think originates from the babysitter motif, right? I mean, whether it's camp counselors babysitting a young Jason Voorhees, whether it's when a stranger calls, the babysitter motif is that if you are put in the position of being responsible for children, do not shirk the responsibility, and certainly don't have sex, because you will not end this movie alive. Right? So again, it's a pro-social warning with regard to the rules of horror and really the rules of the superego. And Judith Myers, violates that first rule. And she's put in a position of responsibility to babysit not only a young Michael Myers, but what we learned in a sequel is that there is another baby, there's another child in that house that we don't see, that's disclosed to be Laura Myers, who of course has to change her name because of Michael to Laurie Strode. So that's one of the reasons why we think Michael comes back, at least one of the story arcs, because there's more than one here. But at least one of the story arcs created by a sequel is that Laurie Strode happens to be the sister of Michael Myers. And they tried, perhaps unsuccessfully, to create that story arc to actually answer that question. Why does he come home? So that's a consideration here too. Another observation from Michael. He's expressionless. He slashes. We think that might be due to acting out. We're really not sure what the impulse is. It may or may not be related to Laurie Strode being Laurie Myers, his younger sister. What else can you observe with regard to Michael?
He has like voyeuristic behaviors throughout the movie.
Yeah, he's a stalker.
Yeah.
And because of the overt sexuality in Halloween, One of the concerns I would have as a clinician is that his stalking behavior is as a goal for sexual gratification. And if that were the case, what might be the single best diagnosis on a shelf exam?
Well, like a certain paraphilia, basically.
Which would be what?
Isn't it called voyeurism? Or
Yeah.
okay.
Voyeurism or voyeuristic disorder. Voyeurism is the behavior. Voyeuristic disorder is when the behavior is clinically significant. Voyeuristic disorder then is the mental disorder, right? That again is hallmarked or defined through clinical significance, clinically significant distress or impairment to self or others as a result of the abnormal behavior called voyeurism. So there's certainly elements of that. Even in Halloween Kills, there is multiple allusions to his not only going to home, back to his home, but going back to his bedroom and staring out the window for some reason that we never fully understand. What was out that window that he was staring at? Why is it that he's even in Halloween Kills trying to get back to that window to stare down the street? So again, was it a voyeuristic act? Other observations?
He doesn't talk.
Yeah, right. So we talked about this the other night, and that through multiple years, multiple decades, this character never utters a single word. And if you didn't pick that up in watching either Halloween or any of the sequels, including the one that just premiered last week, you certainly would pick it up if Michael Myers was apprehended and taken to acute psychiatric services for an emergent psychiatric evaluation, and you were on call. Because I could guarantee you, when you enter into one of those rooms in APS, and through a 1-hour psych eval, the individual named Michael doesn't say anything to you. You know you're not going to simply leave the room because your attending just the past hour said, as part of your residency training, you will sit and you will experience silence comfortably as a clinician. You create a situation in which the other individual demonstrates pressured speech to see what they reach for to initiate the conversation, because that could be meaningful. So here you are, sitting across from a Michael Myers, and he's not talking. Neither are you. So if you miss the fact that he hasn't talked since 1978, you will certainly pick up on it during your psychiatric evaluation. No doubt about that. So, what is aphonia?
Not speaking.
Not speaking
making
due
noise.
to what?
Damage,
Sorry?
right? Like damage to,
Not speaking due to a physiologic pathology. Since 1978, has John Carpenter or any subsequent producer, director, ever given us an indication of an underlying medical cause for Michael's not speaking? Never. Yeah. So what clinical term, specifically mental status exam term, will we use instead of the clinical diagnosis of aphonia?
Could you say
Nonverbal, that would be correct.
Mute.
Mute.
Mutism?
Right. Mutism or mute is a mental status exam term used to describe speech or language.
I have a question. So if you were doing like a mental exam on him, you would sit in the room with him quiet for an hour?
Yeah, I think for an emergency exam, and I said APS, but the fact is, in an emergency room, you're not going to sit for an hour.
Right.
Because the MIs come in and you've got somebody that needs to be intubated. So you're not going to be doing that. The sitting in front of an individual who's not talking and trying to therapeutically get to a cause is more likely to occur in psychotherapy.
Okay.
Right? But you know what? You're in training, and even in an emergency situation, if you did it as a resident, hopefully nobody's going to really be critical of you. But the fact is that this is a psychotherapeutic maneuver, more of it being something you would see in an emergency room.
Okay.
So we think that Michael demonstrates mutism after you do sit with him, whether it's for 1 minute or 1 hour. You call your attending on call and discuss your clinical findings and decide to use the word mute or mutism in explaining, describing Michael's not talking. So, true or false? The cause of Michael's mutism is psychosomatic.
Isn't everything
True.
psychosomatic?
So you're saying true or false?
So true.
No. And why?
'Cause that's what you said.
You said it before, because everything is psychosomatic. It's exactly right. Every single condition, including that which explains the behavior we're observing, has both psychological and somatic components to it, period, so it must be psychosomatic. If we can't understand or find the somatic component to why Michael Myers doesn't talk, then we have to the only thing we can do is focus on the possible psychological factors that are influencing this behavior. And at that point, what clinical term are we likely to use to explain Michael's not talking? Psychogenic. Michael Myers is struggling with a psychogenic illness. Psychogenic illness is nothing more than the psychosomatic illness for which you can't find out what is somatically going on. Hence, psychological factors, therefore, must be deemed to be central by default. That's when we incorporate the term psychogenic. There are 4 major illnesses in a differential diagnosis with regard to psychogenic disorders. What are they? I heard one before. Conversion disorder is 1. 3 more.
The somatic symptom disorder?
Somatic symptom disorder is number 2. 2 more.
Factitious.
Factitious disorder, good.
And malingering.
And malingering, good. So what is the next question that a clinician must address to help differentiate these diagnoses?
Are they concerned about the illness? Because for conversion, don't they, isn't that the love out like the last thing where they don't?
We'll get there. Not quite yet, though.
Are they lying to you? Do they know
That's
they
it.
have it?
Is Michael Myers misrepresenting his symptoms? Is he lying to you? Thoughts?
I don't know.
Probably not.
If you hesitate, the answer is no. Remember, the answer is always no.
Yeah.
We give our patients unconditional positive regard, yes, even Michael Myers, until evidence is produced to the contrary. So the answer is no. All right? If we had discovered that he is lying, right, which would be a nice little cool twist to go back and tweak one of these sequels, what 2 illnesses then would be in our differential upon the discovery that Michael Myers is in fact misrepresenting his symptoms? Factitious and malingering. And then the next question for our clinician is what to help differentiate one of these illnesses from the other?
External reward versus internal.
Perfect. Right? Is the reward external or is it internal? Is it conscious or is it subconscious? The external reward being discovered allows for the discussion of what was formerly known as malingering. In the absence of that, the default is always that it is internal or subconscious, and therefore the provisional diagnosis is always factitious disorder until proven otherwise.
I have a question. So when you say it's
Not aware of why they're doing
do they believe it that this is how they are? Is that
No, they're lying to you.
okay?
There's a conscious effort to deceive you for unconscious reasons.
Are they aware, I guess what I'm trying to ask is, are they aware of the unconscious reasons why?
No,
Okay.
no, no. Again, any awareness of what they're doing really confounds this issue. On the test, this will be well delineated. Unfortunately, in real life, things do get clouded. And human behavior is complex no matter how we try to simplify it.
Yeah.
But generally speaking, the condition of factitious includes the conscious effort to deceive that is motivated by subconscious gain. Gain and motivation here being interchangeable terms. Now, the gray area could be secondary gain, in which the patient does identify that it's pretty awesome to be sick because all these people care about me. I feel like that treats me differently. My physicians, are people that I can interact with. I have lengthy hospital stays. So you can see where the gray area is, and that's called secondary gain. Comforts that are collateral or secondary to being sick. So that's a great example of your point, which is, boy, this line that delineates is not solid, but it's kind of a dotted line. Secondary.
So the secondary gain doesn't make the diagnosis more
Correct.
it's still happening.
Correct. Secondary gain of the collateral or secondary benefits one receives from being ill. Right? And that's differentiated from external gain, which then defines malingering. It also differentiates from primary gain, which is the subconscious, like if there's something subconscious in this individual that is motivating his behavior, that is influencing his being a slasher. So, what differentiates somatic symptom disorder from conversion disorder?
Is it that with conversion disorder, they're not like particularly bothered by the symptoms?
Yeah. Somatic symptom disorder is a multi-system illness. The four common systems include sexual, neurologic, pain, and GI. Those are four very common systems affected by somatic symptom disorder. So it's a multi-system illness. When the system that's affected is only neurologic and focuses on voluntary motor or sensory function, we call that conversion. So in that way, conversion disorder is a subset or a subtype of somatic symptom disorder. But because of its point prevalence, that is, it's common, the American Psychiatric Association pulled it out and created its own diagnostic title for it, its own label. But intuitively, it's a subset. Given the fact that Michael's mutism is likely that of motor deficit, vocal cord deficit, his illness, his not talking, his mutism, is likely a product of the diagnosis of conversion disorder, where an individual has presenting signs, physical signs, mutism, that are manifest from an internal conflict that Michael cannot have come to conscious awareness. So instead of expressing what he really wants to say, he will present to his physician with the inability to talk as the chief complaint. So from a psychodynamic perspective, what is likely, or could we give some specificity to that impulse that Michael cannot have to conscious, or cannot have come to conscious awareness? Generally speaking, for instance, if you saw a heinous crime, the memories of which were too harmful to be able to talk about, you may actually present to your clinician with blindness. Blindness for which no underlying physical cause can be found. Conversion blindness, conversion disorder. If you heard something from your attending that you should not hear, it was so traumatic for you, that you can't possibly have that come to conscious awareness, you may actually go deaf. So, along these same lines, give me a reason, give me an example of why Michael Myers has lost his ability to speak.
He may have said something as a kid, maybe, that something happened to him traumatic, and so he's scared to talk.
That night, if his sister said, Michael, it's time for bed, and he protested, and he said, I hate you, I wish you died. What happens that night may have resulted in this child losing his ability to speak, even through adulthood. So that's a very good example. Anything else? These are the questions that a psychiatrist would have to, I don't think you're going to ask a patient this, because again, to the extent that he can't speak and his mutism is a result of his defense of not remembering, he's not going to be able to tell you. So it's not as easy as asking, he might. What happened that night that you can't talk about? All right, but that's the clinical consideration, and this is where you have to review the record, including probably the police record, to get some idea and information about the cause and effect.
Are conversion disorders usually at one-to-one in terms of?
It can be.
Okay.
It can be. And along those lines, when the underlying conflict is resolved, there can be spontaneous resolution. And this guy can just start singing like a bird. And to that point, conversion disorder actually has the best prognosis of any somatic symptom or related disorder. I mentioned, I think, this morning that factitious disorder had the worst prognosis among the group.
Yeah.
But conversion has the best for that very reason.
For conversion, could it also be like a combination of all kinds of things, and then to like a breaking point type?
Yeah. Yeah, we will use the clinical term multifactorial, but again, most behavior, if not all behavior, is multifactorial. It is that complicated. But sometimes you can actually see cause and effect, and you focus on resolving that inner conflict that is caused by blank, whatever was said that night. And when that is worked through, the individual may recover their speech. Loomis couldn't pull that off, though. So there's another pretty cool case study where an individual has difficulty ambulating. And it looks as if it's rooted in poverty. And upon his family getting money, he drops his cane and walks. What case study am I referring to?
Reminds me of Willy Wonka.
Willy Wonka, well, yeah, I think so.
I was just gonna say, like, I know it's not.
Good case study.
Willy Wonka's got a lot of stuff going on, including that. So I will give you a nod there. It's interesting because, we're talking about Halloween, obviously, in preparation for Sunday. You bring up Willy Wonka, which a lot of people kind of associate with Thanksgiving in November, just because that's where it aired through the 70s. Okay, way before your time. And ironically, the case study that I'm referring to is focused on Christmas. So I think a really great didactic through October, November, December would actually be kind of cool, attaching these three films to Halloween, Thanksgiving, and Christmas.
We should have
Christmas?
a Hanukkah one too. We should have a Hanukkah one too.
We should have
A Hanukkah
Hanukkah
one too.
What Christmas novel, adapted to film multiple times, portrays a child who is quote unquote lame, who walks upon his family getting money? Scrooge. Yeah, if Scrooge doesn't come in and make, I'm blocking on his name now, I don't want to say Crockett, Cratchit, his partner with the Christmas turkey, Tiny Tim's not walking. And a lot of people have rendered an opinion on what ails Tiny Tim. I think the most common diagnosis on Reddit or elsewhere is polio. But I can assure you, even as a psychiatrist, polio does not respond to money the way that Tiny Tim responds to his family becoming rich. Okay. Know what responds to that? Conversion disorder. And it's interesting because once you understand that, you can actually look at the impetus of trying to find the reason behind why Tiny Tim can't walk, can't ambulate. Because in the absence of Dickens telling us, there have been a lot of people, including several MDs, that have written on this, thinking that the absence of information allows for that open door for us to render a medical opinion. The logic is backwards. The reason why Dickens doesn't tell us of the physical cause of Tiny Tim's ailment is because there is none. And once you understand that, you know that psychological factors must be deemed central. That is, his lameness, quote unquote, is psychogenic. And since there really is no evidence that he's lying, and it's dealing with voluntary motor function, the only answer could be conversion disorder. And boy, does the ending, spoiler alert, of A Christmas Carol verify it, confirms it.
It's an interesting connection because you hear of modern miracle stories. Oh, this person walked for the first time after 100 years, like not 100, but after 30 years. My mom's been blind my whole life, but she's miraculously started seeing. So it's just, yeah. So is it all conversion disorder or something in that book? Yeah.
You bring up a great point, because with regard to where this particular fictional case account sits, the only diagnosis that would really be in the differential, not polio, not RTA, not rickets, as has been written in the literature, but Christmas miracle is the only one that makes sense.
Yeah,
Right.
Christmas and then not even non-Christmas miracle. I feel like
Right.
it's like a supernatural sort of description all the time.
I think even with an MD after your name, you have to respect that.
Mhm.
Right? But however, from a physician standpoint, I think it's fair to say conversion for Tiny Tim is the differential. But I don't want to offend the Catholics in the group and take away Christmas miracle. Because obviously that was Dickens' intent here.
Mhm.
So again, I respect that. I have to respect literature as well as the holiday. All right. So by the way, for those of you who didn't intend to talk about Tiny Tim and Michael Myers in the same breath, gotcha. Anything else about Halloween and Michael Myers? So I don't think that Michael Myers' mutism is going to spontaneously remit. And I think that if we were to do this all over again, and if we could have a time machine and get back to 1978, number one, how awesome that would be to relive the 80s. But number two, I think engaging him in psychotherapy would have been something that Loomis may have actually addressed to a greater degree in his treatment plan. And in cases like this, the type of psychotherapy the clinician must consider are nonverbal therapies. Because so you try to engage Michael Myers in CBT or psychodynamic psychotherapy, etc., is going to be very difficult given that he doesn't talk. So music therapy, art therapy, the nonverbal therapies should be of high consideration here. Now, I think in real life, especially in situations in which the individual's conversion disorder is not focused on their voice and therefore mutism, the referral is usually for CBT. But we have to be prepared when it doesn't work. So if it works, wonderful. But if it doesn't work, the nonverbal therapies, nonverbal psychotherapies should be a plan B. The general idea here is that people like Michael Myers have a very difficult time putting words to their inner feelings. And that goes for whether your conversion symptom is mutism or anything else. They're presenting with physical signs to non-verbally communicate with you because the verbal language is so. Even in cases in which the individual is not you, the non-verbal psychotherapy still should be strongly considered. So give CBT a try, but be prepared for it being unsuccessful. Final thoughts, Michael Myers.
I wonder if he's just so ashamed and embarrassed of what he did. Because I just thought it was interesting that in the beginning of the movie, like he walks in on his sister and she's naked and then he stabs her, and then it's almost like, I think when like they were standing outside and he just had this like look of shock on his face, which is interesting because like you would think, I don't know, if he was like evil or whatever, he would be like angry
Animated.
or passionate or upset, some sort of thing. And I just think it's interesting that it follows the theme of like people, like the sexual theme of like, you know, people being naked or people having sex or that kind of thing. So it's just like, I think that's interesting. And also when I watched it that first time and there's the scene where like right after he comes out of the house, the dad takes the mask off. I wonder if they're almost trying to be like, oh, the mask is evil because, you know, like he's like this little boy who we don't learn the intentions of why he did that. Like the minute he takes the mask off of his head, he's just like standing there like shocked.
Yeah, I think he is in shock. He is dissociated when that mask is taken off, which of course then brings into discussion other co-occurring conditions. Depersonalization, derealization disorder, certainly dissociative amnesia. As an adult, Halloween Kills, if we asked, and he was able to talk, would he have any recollection of what he did back in 1978? Well, actually, it was 1963. And of course, even DID, right? So we can even look at the dissociative disorders in that context too. All right, we'll end it there.
Second.